Good day. We'll talk about sodium. This is the first discussion regarding electrolytes. So let's start with our discussion regarding sodium. So sodium is the most abundant cation in the ECF. Okay. So usually, or the common location of sodium, it is in the extracellular fluid, okay, outside the cell. Okay, so if this is the cell, usually sodium is nadere, okay, outside. Okay, this is a cell and this is sodium outside the cell. Okay, so that's for sodium. So remember the mnemonics piso. Okay, so meaning of piso, it's potassium in, sodium out. Meaning potassium is the major intracellular cation and sodium is the major extracellular cation. Okay, so that's for piso. Okay, so sodium is predominantly located in the extracellular fluid. There is small concentration of sodium present in the intracellular fluid. Okay, but it's predominantly located in the extracellular fluid. Okay, so it represents 90% of all extracellular cations. Okay, that's for sodium. And it determines osmolality. So it's a major contributor of osmolality. Okay, so what is osmolality? It's the ratio between solvent and solute over solvent. Okay, that's osmolality. Okay, so regarding the major contributors of osmolality, first you have sodium, the next is glucose, and third you have BUN or urea. Okay, so these are the major contributors of um, three major contributors of plasma osmolality. Okay, so if there's alteration in sodium concentration, if there's increase in sodium concentration, then the osmolality is also increased. Same with glucose and BUN. So for example, um, the normal concentration, okay, or the normal osmolality, okay, plasma osmolality is you have 1 liter of plasma and you have 10 sodium plus 10 glucose plus 10 BUN. Okay, so 10 plus 10 plus 10, that's 30. 30 divided by 1, it's 30. So the osmolality is 30. So let's say that this is the normal, okay, normal plasma osmolality, 30. Okay, now if you ingest, okay, food rich in sodium, rich in salt, automatic the osmolality is affected because you need to add, okay, sodium. Okay, so instead of 10, so ni-ingest ka og food rich in sodium, so let's say ni-add ka 20 nga sodium. So 20 plus 10 plus 10 plus 10, so this is 50. So 50 divided by 1, that's 50. So the osmolality is 50. So it is increased because of the alteration in sodium concentration. Okay, so the body will try to uh, maintain homeostasis in osmolality or balance in osmolality. So the body, or the response or the mechanism of the body or the compensation, is to adjust this one. The body will try to increase the plasma volume so that it will maintain its normal osmolality. Okay, so after ingestion of salty food or kanang food rich in sugar, your body will try to drink more water, okay, to increase the volume of the solvent, which is your plasma. Okay, so for example, if you drink Coke is rich in sugar and also sodium. Okay, So the effect of drinking Coke is increase in osmolality. That's why after drinking Coke, uh, you'll be thirsty. Okay? So thirsty ka, uhawon ka, it's because of the alteration in osmolality. Okay? So that's the effect of sodium to osmolality. So regarding regulation of sodium concentration, first, plasma sodium concentration depends greatly on the intake of sodium and excretion of water. Okay, so for plasma sodium concentration, it is greatly affected if you ingest uh, food or beverage with high concentration of sodium or salt. Okay, and another is the excretion of water. Okay, that's another reason. Okay, or that's another factor that greatly affect your sodium concentration. Okay, the intake of water in response to thirst is stimulated or suppressed by plasma osmolality. Regarding the intake of water or the activation of the thirst mechanism, it is based on plasma osmolality. Okay, so if there's increase in plasma osmolality, automatic, uh, no, if there's increase in plasma osmolality, automatic, your hypothalamus will trigger your thirst mechanism in order for you to compensate, okay, or to stabilize or to normalize the osmolality. Now, if there is decrease in osmolality, meaning there is increased plasma volume or increased solvent volume compared to the concentration of solute, then your body will try to suppress, okay, the thirst mechanism. Okay, will try to suppress the reabsorption of water and also the thirst mechanism in order to uh, gain or to go back to its normal plasma osmolality. Okay, the excretion of water, third bullet, largely affected by ADH release. Okay, or ADH is your antidiuretic hormone. It's also known as your vasopressin, okay, or arginine vasopressin. The purpose of ADH is to uh, the main function of ADH is in the retention, okay, retention of water, okay. So antidiuretic, it prevents what urine formation. Okay. Now that ADH release, okay, is affected by blood volume and osmolality. Okay. So for example, if there's a decrease in blood volume, the body will try to produce more ADH. Okay, to prevent the loss of water, okay, to reabsorb water in order to increase or to normalize the blood volume. Okay, another for osmolality, if there's increase in osmolality, your body will try to produce more ADH, okay, to conserve water, to reabsorb water in order to increase the plasma volume. Okay, now if there is decrease in osmolality, there's also a decrease in ADH release. Okay, so decrease osmolality, decrease ADH release because your body is trying to eliminate excess amount of water. Okay, so that the osmolality will return to its normal level. Okay, so ADH, it's for the regulation of water, and that regulation of water affects your blood volume and osmolality. Okay. Now, regarding that ADH secretion, it also affects the concentration of sodium. Okay, so later we'll discuss what is the effect of ADH or if there is syndrome of inappropriate ADH release. Okay, now regarding ADH, the endocrine gland that is responsible for the production of ADH, it is your hypothalamus, not pituitary gland. Okay. Diba there are two portions of your pituitary gland. You have your anterior, which is the adenohypophysis, and the posterior, which is your neurohypophysis. Okay. Regarding pituitary gland, the anterior part produces hormones, but for the posterior, it acts as a storage, okay, and responsible for the release, but not for the production of hormones, okay. So ADH is stored and released in the posterior pituitary gland, but it is produced by the hypothalamus, okay. That's for ADH, okay. Remember, hypothalamus produces ADH, okay. The blood volume, fourth bullet, the blood volume status, which affects sodium excretion through aldosterone, angiotensin 2, and ANP. Okay. So regarding blood volume, which affects sodium excretion, it's regulated, okay, by aldosterone, angiotensin 2, and ANP. Okay. So regarding this one, for aldosterone and angiotensin 2, aldosterone and angiotensin 2 are part of the renin, angiotensin, aldosterone system. Okay, so if there's activation in RAAS, the effect, you have increased blood volume, okay, and increase sodium concentration. Okay, so meaning of RAS is renin, angiotensin, aldosterone system. So aldosterone promotes retention of water and retention of sodium. Okay, so aldosterone increases blood volume and sodium concentration. Okay, for angiotensin 2, uh, it promotes vasoconstriction. And angiotensin 2 is needed in the activation or stimulation of the adrenal cortex to produce aldosterone. Okay. Now for ANP, this is the opposite to RAAS. Okay. So for ANP, it decreases sodium concentration and decreases blood volume. Okay. So that's for the third slide of our discussion. Next, you have the hormones affecting sodium levels. So first is aldosterone, and second, you have atrial natriuretic peptide. So for aldosterone, it promotes absorption of sodium in the distal tubule, and it promotes sodium retention and potassium excretion. Okay, so for example, if the patient has hyperaldosteronism, okay, meaning there is excessive production of aldosterone, the effect of hyperaldosteronism to sodium level, it is increased because it increases aldosterone increases the it promotes the retention of sodium. Okay, so it's increased sodium, but the potassium level is low. So the patient will experience hypernatremia and hypokalemia if the patient has hyperaldosteronism. Okay. Now, if the patient has hypoaldosteronism, so meaning there is decreased production of aldosterone, meaning there is decreased absorption or reabsorption of sodium. Okay, decreased reabsorption of sodium, meaning there's increased excretion of sodium, no retention of sodium. Okay, so the effect, you have decreased sodium. Now, regarding aldosterone, di ba, it promotes the excretion of potassium. The patient has hypoaldosteronism, meaning the body will retain more potassium. Okay? So there is increase in potassium level. So patient with hypoaldosteronism will experience hyponatremia and hyperkalemia. Okay? So aldosterone. Sir, why man inana nga it promotes the retention of sodium and excretion of potassium? It is to maintain electroneutrality. Okay? Next, atrial natriuretic peptide. So it's an endogenous antihypertensive agent secreted from the cardiac atria. So why man ANP is an antihypertensive agent, endogenous antihypertensive agent? Because it blocks aldosterone. okay, and renin secretion. So aldosterone and renin are part of the RAAS. And the effect of RAAS activation is increase blood pressure, increase blood volume. Okay? Increase blood pressure, increase blood volume. Then you have also increase in sodium concentration. Okay? So it's an endogenous anti-hypertensive agent because it blocks and also inhibits the action of angiotensin 2, which is also part of the RAAS, okay, and also vasopressin or ADH, okay, because vasopressin promotes water retention, and if there's increased water retention, the effect of that is increase in blood volume, and if there's increase in blood volume, the blood pressure is also increased. Okay, so ANP, okay, it blocks aldosterone. So it inhibits the RAAS or renin-angiotensin-aldosterone system. Okay? And it causes natriuresis, meaning excretion of uh, sodium. Okay? Excretion of sodium. That's the effect of atrial natriuretic peptide. Okay, so next, what are the causes of hypernatremia? Okay, so first is excessive water loss. Okay, water loss. So what are the conditions associated with excessive water loss, excess water loss? So first is diabetes insipidus. Okay. So for diabetes insipidus, there are two types of diabetes insipidus. You have the central diabetes insipidus and the nephrogenic diabetes insipidus. So what's the difference between central and the nephrogenic type of diabetes insipidus? So before we'll talk about the difference, the similarity of central and the nephrogenic DI is there is increased urine output. Okay, increase urine formation. Okay, that's for diabetes insipidus. Why? Because for diabetes insipidus, there is a problem with the hormone ADH. Okay, so for central DI, there is absence or decrease ADH production. So if there's decrease in ADH production, your body will not be able to retain water. Okay? So your body will try to eliminate water. Okay? That's why there's increase in urine formation. Okay? The purpose of ADH is to inhibit or to control the loss of water. Okay? Via reabsorption. Okay? That's for ADH. So for central diabetes insipidus, there is decrease, deficiency, or absence of ADH. For nephrogenic DI or the nephrogenic diabetes insipidus, the body uh, is able to produce normal amounts of ADH. Okay, normal ADH. The problem is the receptors for ADH is resistant. Okay, the receptor is resistant to ADH. The ADH receptor is resistant to ADH, meaning there's no reaction between ADH and the receptor. Okay, so that's for diabetes insipidus nephrogenic type. Okay, so for central, there is deficiency in ADH. For nephrogenic, no deficiency, normal ADH production, but there's resistance to ADH. Okay, so both they have increased urine volume or increased urine formation. Okay, next, renal tubular disorder. Okay, there is problem with the reabsorption of water, prolonged diarrhea, profuse sweating, severe burns, vomiting, fever, and hyperventilation. Okay, so these conditions are associated with hypernatremia if the patient has a problem with her or his hypothalamus. Okay? If the hypothalamus is not functioning, meaning it cannot activate your thirst mechanism, then the patient with DI, renal tubular disorder, prolonged diarrhea, profuse sweating, severe burns, vomiting, fever, hyperventilation will experience hypernatremia. Okay? If there's a problem with hypothalamus, or if the patient is an infant. Okay? Because ang infant, di pa man siya ka-demand nga mo-drink siya water. Okay? Same with people with altered mental status. Okay? So hypernatremia, it's not that common in a person with functioning hypothalamus. Okay? Or a person nga maka-drink siya og water. Okay? Kaya diba, for hypernatremia, cause is excessive water loss. So you just need to replace it, okay, by drinking water. Okay. Next, decrease water intake. Okay, decrease water intake and increase intake or retention of sodium. Okay, so example in Crohn's disease, there is increased aldosterone concentration, increased hyperaldosteronism. So there is increased retention of sodium. Sodium bicarbonate infusion. Okay, so sodium bicarbonate is usually used to uh, for hyperacidity. Okay, you'll take sodium bicarbonate. Another is ingestion of seawater and increase oral intake or IV of sodium chloride. Okay, so those are the conditions associated with increased intake or retention of sodium. Okay, so those are the um, disorders or diseases associated with hypernatremia. Okay, next is regarding hypernatremia. If the serum sodium level is greater than 145 millimole per liter, then that is hypernatremia. Okay? Below 145 or 145, that's normal sodium concentration. Okay? Usually results from excessive water loss. Okay? Perspiration and breathing have 1 liter water loss per day. Okay? That's why if there's hyperventilation, it increases, okay, sa water nga mawala per day. Okay? Then, if the sodium concentration is from 150 to 160, it signifies moderate water deficit. But if it is greater than 165, it signifies severe water deficit. Okay? And if there's chronic hypernatremia, it's indicative of hypothalamic disease because it's easy for our body to avoid hypernatremia if our body is able to trigger or to activate the thirst mechanism. Okay, why? Because if there's excessive water loss, to compensate that one is to drink water to activate your thirst mechanism. So if there's no activation of the thirst mechanism, then the patient will experience chronic hypernatremia. Okay. Next, thirst is a major defense against hyperosmolality and hypernatremia. Okay. So that's why uhawon ka. Okay. Maybe there's a problem with your osmolality. Maybe there's alteration in your osmolality or there's alteration in your sodium concentration. Remember the three main contributors of osmolality: sodium, glucose, and urea. So if there's increase in sodium or increase in glucose or increase in urea, your body will activate your thirst mechanism. Okay? So that's why if mo eat kag cake, after eating cake, your body kaya mo signal siya or it will give you signal to drink water. Why? Because of the increase in osmolality. Okay. Okay, so next condition, we have hyponatremia. So for hyponatremia, first cause is increased sodium loss. So for example, if you're using diuretic, okay, so diuretic use. So for diuretic use, it inhibits ADH, so meaning there is increased urine formation. Okay, so if you form urine, you usually also eliminate some of sodium. Another is diuretic is an antagonist of aldosterone. Okay, so meaning instead of promoting retention of sodium, um, the aldosterone has no effect. So meaning there's increased excretion or decrease in the retention of sodium. Okay, that's why there's increased sodium loss. Okay, another, there's increased water retention. Okay, so for increased water retention, there are conditions associated with increased water retention. So first is renal failure. Okay, so for renal failure, uh, if this is your blood vessel, inside the blood vessel, that's your intravascular. Okay. Outside the blood vessel, that's extravascular. In renal failure, the patient will experience edema or swelling. Okay. Why? It's because of the transfer of fluid from intra to extra. So there's accumulation of fluid in the interstitial spaces. Okay. So that's why more inflame. It's because of the accumulation of fluid in the interstitial compartment. Okay. Now, to compensate that one, the transfer of fluid from intra to extra, your body will produce more ADH. Okay. Produce ADH, produce ADH, produce ADH to normal or to increase the blood, to increase the amount of fluid in the intravascular space. Okay. And that would result to dilution of sodium. Okay. So that's for renal failure. Same reason or same explanation with hepatic cirrhosis. Okay. Next, aldosterone deficiency or correction, it's adrenal insufficiency. Okay. Aldosterone deficiency is part, okay, of, or it's a type of adrenal insufficiency. So if there's adrenal insufficiency, there's decreased aldosterone and decreased cortisol level. Okay. So if there's decrease in aldosterone, there's decreased retention. Okay. Retention of sodium. Okay. And if there's decrease in cortisol, this one will result to increased release of ADH. And remember, ADH is for water reabsorption, meaning there's the effect of this one is increased water retention. Okay? So if there's increased water retention, the sodium concentration is diluted. Okay? Next, cancer. So cancer is associated with SIADH, meaning there is syndrome of inappropriate ADH secretion. Okay. So what is syndrome of inappropriate ADH secretion? There's ADH secretion, but the cause of that ADH secretion is not the normal stimulus of ADH secretion, but other stimulus. Okay? So in patients with cancer, the cancer cells produce ADH, and also the chemotherapy, okay, stimulates your body to produce more ADH, and the pain, okay, in patients with cancer, that pain, okay, stimulates the production of ADH. That's why it's syndrome of inappropriate ADH secretion. Okay. Now, if the patient has SIADH, the patient will experience hyperbulimia or increased blood volume. Now, if there is increase in blood volume, that increase in blood volume will trigger your body to produce ANP. Okay. Atrial natriuretic peptide. And that atrial natriuretic peptide will promote the excretion of sodium. That's why the patient will experience hyponatremia. Okay. Next, primary polydipsia. So for primary polydipsia, there are two types: the psychogenic and the second one is dipsogenic. Okay. So what's the difference between psychogenic and dipsogenic? For psychogenic, it's usually associated with psychiatric disorders. Okay. Example is schizophrenia. Another is depression. Okay. So people with depression or schizophrenia, they tend to drink more water. Okay. So that's the cause, okay, of hyponatremia. Okay. Another is dipsogenic. For dipsogenic, there is compulsory water drinking. So for example, if you think that drinking a lot of water, excessive amount of water is healthy, okay, so that can cause dipsogenic polydipsia. Okay. And if you have hypothalamic disorder, okay, that's another cause of dipsogenic polydipsia. So meaning there is continuous. So for dipsogenic polydipsia, uh, another cause of dipsogenic polydipsia, I have um, hypothalamic disorder, meaning there is continuous activation of thirst mechanism. So meaning there is continuous uh, meaning your body di niya ma-stop nga mo drink og water. Your body is continue siya nga nag-crave siya og water, nag-need siya og water. Okay? And that can cause dilution of sodium concentration. Another, you have CNS abnormalities, then mixed edema. Okay? So for mixed edema, it's a type of um, problem with the thyroid. So there is hypothyroidism. So there is low cardiac output. And that low cardiac output will result to kidney problems. So if you have kidney problems, diba, you'll experience edema, then your body will try to compensate it by producing more ADH, and after that, there's dilution in sodium concentration. Okay? So regarding hyponatremia, it's the most common electrolyte disorders. And if the sodium concentration is less than 135 millimole per liter, that's hyponatremia. Okay? It's a clinical concern if the sodium concentration is less than 130. Okay? And if the urine sodium is more than 20 millimoles per day, uh, the reason, okay, of the decrease in plasma sodium concentration, it's renal loss. Okay. Then for if it is less than 20 millimoles per day, meaning the reason for the decrease in plasma sodium concentration, it's extra renal, meaning it's not because of renal loss. Okay. Next, for every 100 mg per dl increase in blood glucose, serum sodium decreased by 1.6 millimoles per liter. Okay, why? 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 Why there's a decrease in sodium concentration if there's an increase in glucose concentration? Okay, so for example, the let's say that the ratio, okay, so there's 10 glucose and 10 sodium over 1 liter of plasma. So if we're going to compute this one, it's 20 is to 1, so the osmolality is 20. Now if we add more glucose, so for example plus 20, okay, so this is 30 plus 10, that's 40. 40 divided by 1, that's the osmolality is 40. So there's increase in osmolality. So since there's increase in osmolality, your body will try to reabsorb more water or drink more water in order to increase this 1 liter of plasma volume. So to make this 2 liters. So 2 liters, 40 divided by 2, that's 20. So it returned to normal osmolality. But the ratio, okay, of sodium to plasma volume, it is decreased. Okay, so the sodium concentration before the reabsorption or before drinking water, it's 10. Okay, but after, okay, reabsorption of water and drinking of water, the ratio na between sodium and plasma volume, it's 5. Okay, that's why there's decrease in the concentration of sodium. Because regarding concentration of analytes, it's just a ratio, okay, of the amount of solute and the solvent. That's why ang unit, diba, for glucose, it's mg per dl. Okay, dl, okay, that's the unit of your plasma or plasma volume. Okay, mg, that's the concentration of glucose. Okay, that the amount of glucose. Okay, next, SIADH, there's excessive water retention. Okay, so remember the disease or condition that is associated with SIADH. So example, cancer. Okay. Next, symptoms of hyponatremia occurs when the serum level is 125 to 130 millimoles per liter. And usually, if we're talking about electrolytes, uh, specifically sodium, it affects your neurotransmission. Okay, so usually the symptoms are associated with the central nervous system. Okay, if there's alteration in your sodium concentration. Okay, next is pseudo hyponatremia. It's caused by a systematic error in measurement and if there's in vitro hemolysis. Okay, so for in vitro hemolysis or hemolysis, meaning this is your red blood cell, and your red blood cell contains ICF or intracellular fluid. So if there's a damage or destruction of RBC, this ICF will mix with your ECF or plasma. Okay, so there's increase in extracellular fluid, meaning there is dilutional effect, okay, to your sodium concentration. So hemolysis is associated with the dilutional effect to sodium concentration. Okay, and another for artifactual hyponatremia, if there's hyperlipidemia and hyperproteinemia. So same ni siya explanation with katong increase in glucose. Okay, your body will try to compensate it by reabsorbing more water. Okay, so regarding methods for the measurement of sodium, so first you have flame emission photometry, then ion selective electrode. So for ion selective electrode, it's the most commonly used method. Okay, and you're using glass aluminum silicate as the electrode for the measurement of sodium. So it is selective for sodium, glass aluminum silicate. Okay, another is atomic absorption spectrophotometry, and last one is colorimetry. So for colorimetry, it is based on color development. So next slide will discuss to you or discuss the colorimetry method for the measurement of sodium. Okay. Okay, so for this one, I will discuss the colorimetric method for the determination of sodium. So principle, the present method is based on modifications of those described by Maruna and Trinder, in which sodium is precipitated as the triple salt sodium magnesium uranyl acetate with the excess uranium, then being reacted with ferrocyanide, producing a chromophore whose absorbance varies inversely as the concentration of sodium in the test specimen. Okay, so explanation. In your specimen, sodium is present. Okay, so this sodium will react with uranium, or will use uranyl acetate and magnesium acetate to form a precipitate. Okay, and the name of that precipitate is sodium magnesium uranyl acetate. Okay, so if there's sodium in your specimen, this sodium will react with uranyl acetate and magnesium acetate to produce a precipitate, okay, which is your sodium magnesium uranyl acetate. Okay, so there's precipitation. So if you mix the serum with the reagent, the filtrate reagent contains uranyl acetate and magnesium acetate. Okay, so after centrifugation, there will be two layers. Okay, the precipitate and supernatant. Okay, so all sodium will be in the precipitate area. Okay, and the excess uranium is present in the supernatant area or supernatant fluid. Okay, or the supernatant. Okay, so in the precipitate, you have the sodium, and the supernatant contains the excess uranium. Okay, this excess uranium, uh, you mix it with a color reagent, or you use ferrocyanide. So the uranium present in the supernatant will react with ferrocyanide to produce a color. Okay, so meaning if there is more free uranium present in the supernatant, the color development is much or more intense. Okay? So, saan siya paghatag example or pag mice. Okay, let's say there are 10 available sodium in the specimen. And there's also for uranium acetate and magnesium acetate, there's 20. Okay? So 10, so 1:1 ang ratio ha, 1 sodium for 1 uranyl acetate. So these 10 sodium will react with 10 uranyl acetate. So to produce precipitation. So the free uranium is 10. Okay? So once ferrocyanide is added to the excess uranium, the intensity of the color is 10. Okay? Because na may 10 nga free uranium. Okay. Now, what if the sodium concentration in the specimen is 18? Okay, so it will react with 18 uranyl acetate. So the number of free uranium or excess uranium is now 2. Okay, so if we mix it, or the free uranium or the uranium, mix it with ferrocyanide, the intensity lang sa color is 2. Less color development. Okay, because there is less uranium present. Okay, why man less ang uranium present? Because there are a lot of the concentration of sodium in the specimen is increased. Okay, more sodium, more precipitate form, less uranium present in the supernatant. Okay, that's why less ang intensity sa color. But for specimen with low sodium concentration, meaning low precipitate or less precipitate form, more free uranium. And that uranium will react siya with ferrocyanide to produce an intense nga color. Okay, so hopefully na-gets na to siya. Okay, so for the preparation, you need 4 test tubes, one for blank, one for standard, one for control, and one for patient or specimen. Okay, so for the 4 tubes, you are going to add 1 ml of filtrate reagent per tube. Okay, so 1 ml, 1 ml, 1 ml. So the filtrate reagent contains the uranyl acetate and magnesium acetate. Okay, then after, you put 50 UL or microliter of distilled water for blank, and 50 UL of standard reagent for standard, and 50 UL of control reagent for control tube, and 50 UL of serum for patient or specimen preparation, okay, or for the patient sample. Then you centrifuge it for 10 minutes. So after centrifugation, you have 2 layers, diba? you have the precipitate and supernatant. Okay, so the precipitate contains the sodium, and the supernatant contains the free uranium that will react with the ferrocyanide. Okay, so remember, for blank, blank meaning zero. Okay, zero concentration of sodium. Okay, meaning after centrifugation, there's no precipitate form and liquid lang tanan, no precipitation. Okay, because does not contain any sodium. Okay, for standard, it has it will have, okay, a precipitate, it will have a precipitate, same with control and patient, because these tubes contain sodium. Okay, so after that, you will use the supernatant from the first four tubes. And for the second procedure, we are going to prepare another four tubes, one for blank, one for standard, one for control, and one for patient. Okay, so the supernatant from this blank tube should be transferred to this one. The supernatant from this one to this one, supernatant from control to control, and the supernatant from patient to patient tube. Okay, so in your four new tubes, you need to add acid reagent, 1 ml of acid reagent per tube, and you need to add 50 UL of supernatant. Okay, so 50 UL of blank supernatant for blank, and 50 UL of supernatant from 50 UL supernatant from your standard tube to your new standard tube. Then same with control and patient. Then after, you add color reagent. Okay, so this one, the color reagent contains ferrocyanide. Okay, that will react with the uranium present in your specimen and standard and control. Okay, after that one, mix by inversion and zero the spectrophotometer with distilled water. So you cannot use this preparation of blank for to zero the machine, because it has an absorbance reading for this method. So we'll use a distilled water as blank or water blank for this procedure to zero the spectrophotometer. Okay. So after reading the absorbance, so for example, the absorbance for uh, blank is uh, 1.406. Okay, 1.406 for blank. For standard, it's 0.803. So 0.803 for standard. For patient, it's 0.880. Okay. And for control, it's 0.890. Okay. So take note of this blank, absorbance reading. Okay. So sir, why man the blank has higher absorbance reading? It's because of the absence of sodium. So there are more, or the concentration of free uranium is higher compared to other test tubes which contain sodium. Okay. So that's the reason why the blank tube is or has higher absorbance reading. There is the absence of sodium in blank tube. Okay, so meaning there is higher concentration of free uranium. Okay, so for blank there is no sodium concentration. Okay, so there is high concentration of uranium in your blank tube. That's why higher siya o absorbance reading. So let's try to compute for the concentration. Okay. So for the computation, you need to follow this one. So absorbance of blank, which is 1.406, minus absorbance of specimen or patient, which is 1.880. No, not 1 point, 0.880. Then absorbance of this of blank 1.406 minus absorbance of standard, which is 0.803, times the concentration of the standard, which is 150. So for this reagent, the concentration of standard is 150. So minus divide times 150, the result will be 131. So the concentration is 131, okay, for the specimen. So, sir, is there a need to compute for the standard concentration? No, it's given. Okay, how about the control? Okay, so for control, just replace this one with absorbance of control. Okay, and you can compute for the concentration of the control. Okay, so that's how we measure sodium concentration using colorimetric method. Okay, thank you.